Hi, everybody. Can you hear me with the mic? Hi, Karen. So I'm here to talk about the future. Let me see. The future. Certainly in human history, we have faced changes, industrialization, technology, that for the people who lived in that time, the future seemed insane, impossible, untethered from reality. And I think today, our generations that live now are facing a similar kind of fear and awe about the changes that are happening, right? Can you think of some that bring you fear and awe? Somebody answer. The audience feels far, and that makes me feel anxious. Yes. Climate change. Our earth is literally burning. And what does that mean for your home to not feel secure? Anybody else? I can think of at least two that, yeah. Yes, AI and aliens. It's like, which of the overlords are going to come, right, and take over? Which of these changes is going to happen first? So, but there's also something very interesting about this change, because I think in human history, we also, in living through this time, have the opportunity for our history, our epigenetics, to train us in our blood, in our bones, and in our minds, to reinforce the skills and the knowledge that helps us survive the horror and root ourselves in the hope to survive this change. And thinking about the future is something really hard for me. When I was 8, I found myself sitting in front of a bathroom. Like, why I am in front of a bathroom, I do not know. But what I was certain at that time was I was going to die. That is what it felt like. My heart was beating in a way that I could not understand. I could not breathe, choking on my own breath at 8 years old. And the walls in the room was simultaneously large and small, all at the same time. And I remember looking at the floor and thinking, what? This is what it feels like to die. You know, and it was now looking back and as an adult, realizing that this was my first experience of knowing what it felt like for my brain to convince my body to do the impossible. And then 11, not that much further along, I'm sitting in the kitchen. Again, I don't really know why I'm picking these strange spaces in my house, you know, where I lived. And I thought, hey, I've been thinking about death all this time. For the first time in my life, I think I know a way. I finally have the fortitude and the means to execute what I wanted. And I wasn't scared. That's what's weird about that, you know, and it still freaks me out. It doesn't feel scary. Death was an invitation. It felt like peace. And that's depression. It's absolutely wild. And I chose to live that day because my nephew, only 3 years younger than I at that point, only person in the house. Why were we alone? I have no idea. He just starting his own mental health journey, looking at me and was like, chose to stay alive for him. So the future feels tenuous to me. You know, weird that y'all would invite me to come speak about the future. Because forever it felt like far away. I didn't have the benefit of thinking about the future, but as I got older and I learned to live and chose every day to live, choose every day, wake up and choose to live, that I feel grateful that one of the benefits is that if I allow myself to stay in the adventure of life and allow myself to get to focus deeply on this, on the awe, that what I found is that one of my deepest values in my life, we went through an exercise at Mental Health America about values. I realized that one of my deepest values is curiosity. Because curiosity saves me. It allows me to ask questions about where I come from and why I have the brain that I have and why my family chooses to make the choices it does, and asks me to think about humanity and the choices we make and to have empathy and understanding suffering, right? And so, as with most people with disability, you know, I realize that I follow this path, and in my work, you do what you know, and I know mental health and I know mental illness. So if I didn't do this, I only recently was like, I think I would have been like a physicist or something cool, but instead I'm here. And we're gonna make the most of it. And what I wanna do with you today is bring you on my journey of curiosity. What I get to do at my work, because I found my home, I found my people at MHA who value lived experience, and what that means to say, okay, let's take this journey in a world where we don't know anything, y'all. You think we know anything about mental health and mental illness. We don't know anything. And that's kind of a cool spot, you know? So I'm gonna take you on this journey of what we've been curious about and what we've been exploring and the questions that we ask. So there's a lot of things here. And I'm trying to infuse, you know, something interesting in all of these things that sometimes can feel very wonky. So are we ready? Are we cool? All right. So data. I'm in research, which is funny because I am not, like, I don't have a PhD. I'm a social worker. I'm a consumer. I love that MHA lets me do this. We have research reports that look at our traditional sources of data. You know, Karis Myrick sitting here speaking today was asking me about, like, how do I understand workforce shortage? The government has put out surveys. County mental health systems have tried to answer this question about data and try to help our policies develop from these systems, these traditional sources of data. But when I think about change, and I think about the future, and I think about innovation, I think about where we have data that we're not using. Right? So MHA collects data online, and this was entirely by accident. And I'm going to show you some of the data that we have. But I remember sitting in a meeting, and we were asking about prevention and early intervention. And we spend so much time looking at healthcare data. But if I look at healthcare data, is healthcare data prevention? The answer is no. It's not, right? It's not. It's like, I don't know how long it takes you to get into your system. But even as somebody who's really adept at getting into my system, it still takes me months. And then forget it. Like, if I'm in an episode and I haven't connected with my therapist, my brain is basically telling me, forget it. Just don't even bother, right? But I remember the first thing you do when you know you need help, what do? You go on the internet. You go on the internet. At best, sometimes I'm looking at my provider's website, and I'm trying to answer the question, like, how do I get in this system? So if a system wants to identify how long it takes for somebody to go from when they first ask these questions to when they can finally get into the system, I'm not looking at healthcare data to answer that question. And it sometimes is still surprising that we aren't thinking about these things, using the data that are available to us to be innovative, to solve these questions, and we're still using enormously old data to say, like, this is the duration of untreated mental health, when I look at online data, I'm like, what is the duration of optimal engagement? What is the timeline, the window of optimal engagement? And so we have tools on our website at MHA, and I'm gonna go through this really fast because these aren't important, but they are resources I'm happy to share. But MHA, Mental Health America, has been fighting for ubiquitous mental health screens forever, 100 years, in fact, since 1909. We have documentation about how even then we were like, can you just screen, ask the questions? So we threw some stuff on the internet back in 2019 and found that many people, mostly youth, come onto the internet because they, like you, when they first struggle with a mental illness, Google. I wish I had Google to say, am I stressed or depressed? I want to die. How do I kill myself? These are the questions that children ask when they come to our site, they are scoring severe, moderate to severe on most of the conditions, or positive for the conditions. They have insight. They know something is wrong already, and they're coming and they're looking up, they're trying to take a test. 54% of them have never been in treatment before. Okay, so we have an opportunity to have the earliest intervention. Suicidal thoughts among youth are the highest. You have heard this stat over and over again. Our future is bleak. We have the technology, the AI, the insecurity, workforce development. We're talking about, well, what does that even look like in the future when the earth is burning down? I think our youth have some insight into this, but the numbers, I think, are very interesting, that even at 8 and 10 years old, 2,000 of them, very small percentage of our overall screeners, are struggling with the highest thoughts of death and suicide, but that stays through your teens. And I don't know how many of us are thinking about workforce development from a youth perspective, and that's the biggest thing I kind of want to impart right now. Our data has been cool because it allows us to map need at a county level in real time. MHA has been committed to putting out our data on a quarterly at best, or every 6 months real-time data from 2023. All the federal data I find is 2 years behind. So if we want to be innovative, how are we using data? How are we sharing data, collaborating on data to make effective change? Our future workforce. I showed you the youth in despair, and I talk about what it feels like to be a child wrestling with these hard topics, because I think that's the reality, is that many of us know that these issues happen at a younger age, but we don't have the power to do anything about it until we're in our 20s. When I go to college and I have insurance, maybe of my own for the first time. These stats, we've been looking at addiction at MHA, and these stats are just a reminder, again, of even for the most profound issues, like how I'm going to use substances to cope with my mental health challenges, are screaming there. I mean, I think the opioid epidemic is a clear indicator of the distress and despair that is happening in the country. But here, I think, for MHA, what's important is the age. The age, that even 50% of our youth and our population, the representation of age here is about 50% are under 25 years old, struggling with more than one substance, more likely than not. And I remember the first time I did drugs, I was about 8 or 9 years old, and I found cigarettes. And I'm like, okay, as an adult, that now makes sense. My brain was like, sweet, this wakes me up. But did not have, I think about this all the time, just like what does that mean to have a workforce that is prepared and trained to do the right thing in prevention and to handle despair. So if we think about the future, we also have to think enormously about despair, because we talked about the change, and we talked about that I could sit in fear and I can sit in horror. And this is what our children are sitting in. They have so much insight. These are their words. We ask them to just fill in the blank about what's going on for them, what is their concern. And there's so much insight here. My brain wants to kill me. How many times have I thought this actual question? That to struggle with a mental illness means my brain is literally trying to kill me, convince me that that's the right thing to do. And so at MHA, we very much care about peers. And I think increasingly we're moving to youth peers. Because I worked in workforce development for a period, and I don't know about you, but when I was young and somebody said, what do you want to do? I had no idea how is one supposed to know, especially when you don't even have access to what is a job? I was like, what have I seen people do? Or what does my parents tell me that I should do? But I did not have access to the breadth of opportunity in workforce. And so a big part of my work at MHA in the past at some of our affiliates was to start getting as young as high school age, to teach them about what mental health is, but also teach them about what it looks like to be a mental health provider, which most of them didn't even think about. And so as early as high school, youth who are wrestling with their mental health problems learn the skills to support one another, and infused that early, converted even, to what it means to turn your suffering into power and to support other people. And that is so cool, because the youth that I work with then are now social workers, psychologists, researchers, doctors. They've been inspired, and that's the way. That's what innovation in workforce looks like. Not looking at curriculum or yes, do that, but what can innovation look like? How do we get in those communities and start from the very beginning? And I'm going to end with technology, because I don't know. This ties in future, and I think that it makes me anxious. A couple things. At MHA, we have a new tool called Changing Thoughts with an AI Assistant. And I don't know if you'll be able to see this, because I'm going to kind of walk through. A person submits. This is basically transitioning cognitive behavioral therapy and cognitive restructuring, and then using artificial intelligence into the AI helps them categorize their negative thinking into specific thinking traps. Then they have to pick the thinking trap, and then we've tested, like, if the AI tells you your thinking trap, which ones do you pick versus when you organically have to decide yourself, which is sometimes what therapy looks like. And then you have to work on reframing your thought, and then you pick the reframed thought, and the AI generates this reframed thought. And we are teaching this AI to engage in human empathy, which is not, I think what most AI that started was not inclined towards that, which is a whole nother topic. And then can you work with what the machine gave you to continue to reframe, reformulate your thought? Okay. So let me go back actually on this, because I am going to finish. I don't know, technology in the future. Sometimes I'm actually freaked out that MHA and our small little company has access to this. And what it means when technology trickles down. And the fact that I could even work on a project like this is really interesting and telling, because I know that the machine that I work with, which was GPT-3 and now 4, we're thinking of transitioning there, pales in comparison to the intelligence that's being trained at technology companies, right? And the discourse that's happening around the country about when we're going to advance in technology so fast that technology itself will think and create and breed, and will no longer need human intervention to make decisions, but that we as humans will rely on technology to make decisions. And that reality is coming sooner than later, like 15 years, and I can't even be dead. I'm going to see that reality. So if I let myself sit in fear, then it's just so overwhelming, and I'm so overwhelmed for fear for myself and children and the future. And then I take a breath and I try to sit in adventure and sit in awe. But then I think that there's a responsibility for us as mental health professionals, maybe even, to speak up about new intelligence and to say, we have been through suffering, and if you train a machine to only think about these subsets of humanity, that's dangerous. Are we inviting enough people to be in this work that also trains the machine to sit with empathy and human suffering and the beautiful sides of human brains? Because otherwise I'm a little afraid that we're bent on destruction, and our values are misaligned with what would be required for us to survive and to succeed. And so I'm so glad I have all of you to help me figure this out, because everybody I've met in mental health is just really beautiful and wonderful. And I think it's because we do have the privilege of saying that we sit in this space where mental health is so exploratory. and there's unknown opportunity to explore. So thank you.
So Theresa and I are going to have a little bit of a conversation, but first I really want to thank you for sharing so much. Theresa and I have had the chance to work together on a previous project, but I appreciate your story being added here today. Thank you for that. You've given us a lot to think about, and I know AI is on everybody's mind, or 99% of people might be thinking about it, and I know we at Kaiser Permanente certainly are. So I really appreciate that you brought that to the table. But I do want to maybe go big picture here, and if we think about mental health quality and the workforce, and I think your presentation hits on a number of components there. What do you wish policymakers really understood about this?
About AI or about workforce?
About, let's take workforce and quality.
How many times do you have to scream about money? And investment. So leadership is charged with making decisions about how money is spent. So if I think about what I wish most, I wish that we all could ensure that we were prioritizing funding where it mattered most. How much does a family invest in a security system versus how much a family invests in food, in exercise, in healthcare, in bicycles, in all the things that bring health? And so investment, because I don't know, y'all, we are constantly crying and screaming and asking for more budget, more money, and it pales in comparison to some of the spaces that money is being spent. And you ask yourself about where our priorities are, how fear and inspiration or awe is driving our priorities.
Yeah.
So.
Yeah. So I also, while I'm asking Theresa some questions, I would encourage questions from the audience as well. We have Nani on our team will be walking around with a mic if there are questions. So I guess, there's a lot that you shared that makes you anxious about the time that we're in. Is there anything that brings hope for you?
Oh, the youth, you all? Our children are so fierce and scary. But I mean, they're kind of inspirational, and they have technology and power and knowledge to make change. And if we could embrace that, I've seen how maybe they can help us move along in ways that we couldn't before. If we could also not lean into some kind of generational divide. Because they're going to be the ones that have been living in the world that we didn't, and so they'll be able to consume and understand technology in ways that we couldn't either. And so I think that survival will also depend on our ability to hear and listen and grow rapidly, and we're going to do that better if we have an intergenerational approach to change. And that's something that I don't think has happened as fast as it's going to, and that's also going to be, I think, hopefully exciting to watch. But youth are creating. We have more youth at the table at MHA than ever before, and they have pushed us to ask questions about hope. Thinking about radical hope. So some of the dialogue at MHA is not about symptoms and depression and like these old clinical things. They're like, no. Let's talk about social media and radical hope. And I'm like, what? That's okay. Let's talk about it.
Yeah. And can you describe what radical hope really is for folks that you're talking to, for the youth that you're talking to?
They just gave us a 2-hour lecture on radical hope because I think that they have to wrestle with radical hope because their peers teenagers, youth in college have faced a kind of real existential crisis we didn't. And they're really using the internet to try and pull anything that could mean. And they're wrestling with it from a philosophical, in the way that I describe, but it took me to my 40s to be able to describe and say, I feel hope and despair. I feel despair and fear. And I could sit in this fear and despair, or I can think about hope. I'm not, and I learned not to talk just about like my PHQ-9 score or whatever it is, but okay, so where do I go to look for hope? And also learning how to control your technology and the way that it influences your brain. They're so much more adept at this, at understanding how to. We're sitting in like trying to decide what amount of time or when do we expose our children to technology, and they're already at how do I use technology, how do I set limits, how do I use the technology to set limits and understand myself and find meaning and find hope. And so I can already tell that they are way ahead of us in processing the meaning for this kind of work.
That's great. That gives me hope as well.
Yeah.
Let me see if there's any questions out there. Yes, great.
For all that you're doing. I'm wondering about schools. How can we use schools to make a difference? The schools are crushed in terms of their funding, but is there anything that we can be doing to really use schools? I hear all the time, you have an elementary school with 300 students and one counselor.
Yeah.
You have one psychologist for multiple schools. So what can we do in schools, both in terms of early prevention, but also in terms of early detection and movement into treatment?
Yeah. We have been pushing a lot for just mental health education in schools, because if you think about health class, I learned about my period. I mean, we learned the basics.
Yeah.
But humanity has been afraid to talk about the brain, probably because we don't know much about it. But there's some progress happening at state levels across the country to reinfuse mental health education as part of health education. I think that's the bare minimum. And that also allows schools to infuse that into curriculum, which is a real barrier for schools. Like, you can't just add things on top of what schools are expected to do when they raise our children all day. Mm-hmm. I think what's also cool is thinking about after school. Sometimes these are the places that the most needy youth and children are there, because their parents can't pick them up at 2. Certainly my parents couldn't pick me up at 2 o'clock. So I went to, the YMCA comes in, or some program comes in and provides out of school activities with the school invest in that space. That's a really interesting opportunity to use. So at MHA, we're kind of exploring what investment in these school adjacent systems could look like to kind of wrap around an environment. And then I talked about workforce. So I want to take away, let's start just thinking about not just curriculum, but let's go into the schools. Let's get youth energized to, again, turn their suffering into action and start doing that conversion early, because I think that, when I worked with youth with psychosis, by the 10th grade, many of my kids were dropping out of school. When I was doing workforce development, we were starting at high school. I'm like, what would it look like if I could start at middle school? But also, did anybody love middle school? It sucks, right? Middle school is torturous and just so rife with bullying. And so how do we think innovatively about these critical lifespan development periods, and then invest in innovative ways that allow schools to get around some of their barriers? What does workforce development in middle school look like? Nobody's ever done that. I think that would be a really interesting space to grow.
I also know that for Kaiser Permanente, we do work in schools as well through our Thriving Schools program. And one area of focus, though, has been on teachers and teacher mental health, because they're in need, they're stressed, they're working with children that are in need and stressed, and so supporting the teachers and faculty is also something really critically important.
We're losing teachers faster than we can keep them.
Yes,
yeah.
Yes. Other questions? Great.
Hi, Lee Wilson Hall from the Camden Coalition in South Jersey. Thank you for your remarks. Thank you for also sharing your personal experience. It's not easy to do in front of a group of people you don't know. It just sets such a nice foundation, I think, for the day. My question is about I really appreciated your remarks about measuring access to mental health and what you were saying about how do we identify when someone actually says, I want to access an appointment or healthcare, the time between that and when they're actually able to connect. A lot of the work we do is working with partners to look at improving access, but then at the end of the day, a lot of the data we have access to is the end result, is whether they actually made the appointment. And we can see the no-show rate, the gap between identified mental health need and treated need, but we have a lot of difficulty really getting access to the data that measures what happens in between. And I think we end up relying a lot on qualitative data, which is so important. But just curious how you and MHA are thinking about that and if you have any guidance around data sources.
Yeah. I except to flag that people have data that they're not thinking about how to use innovatively, I haven't figured out how to get them to commit to also pulling that data, because it's there. That's the thing, right? And I think we get so accustomed in our ways to look at the data that we're used to looking at. And that's coming in at an enormous rate. And that's why using healthcare data is so where we've gone. Mm-hmm. But if we want to think innovatively, we have to build out our workforce and our data scientists and our systems to be able to say, well, you know what, can I get your website data?
Yeah.
Can I get the data from how many people called or just opened up that browser? Most people aren't calling, but on, your browser data, just, hey, could you, people also have to log in sometimes, so can I look at the login? What was the time period between when they logged in and tried to look for that resource and when they landed in your ER? Mm. And if you're looking to save money, then you're gonna try to be strategic about what we've been calling the window of optimal engagement. Because I think that window happens way faster than we think, and if you're really trying to save money, then you're using all the resources you have to move investment from just looking at ER data and healthcare data and trying to be innovative about the other non-traditional sources of data that allow you to peek into what's happening in those earliest stages. So that's what our screening program has, I only started thinking about this because of the accident that happened as we think about screening, but we did a research project with Microsoft Bing, just looking at how many people start searching for depression tests and I want to die, and then who's transitioning to what they're searching right afterwards. And we found that even for people who were scoring mild in anxiety, for example, that within 40 days, they were searching active suicidal thoughts. Mm. And I was like, what does that mean if my old assumptions that I had 10 years for some vague sense of a duration of untreated mental illness, but in today's reality and our data that we have access to, 40-day window. But I don't also think that those youth have, they might not be getting into systems. Right. How long do they exist in suffering before they actually access healthcare? If we're truthful about trying to prevent suicide, are we going to ask these hard questions and respond to what the data are telling us? Or is it just too much? And we just don't have the political and the public will to do something about it? I don't know. It's there. And we'll use it.
Yeah, thank you for that question. And we are unfortunately out of time, Theresa. So I do want to thank you, though, again, for your story and for connecting the dots between your experience, the work you're doing, and sort of what you're hearing and learning along the way. So thank you so much for that. So now I think we're going to move to our next session. So thanks, Theresa.
Thank you.
Thank you.